Today I'm going to go over everything you need to know for your Exam 3, which will be in Module 10 of Immunology. One of the first things we started with were the immunoproliferative disorders. The most important thing you can know with these are be able to pick them out within a multiple choice question. So do you have to know every single piece of data with every single one? No. But you do need to be able to recognize things. So if something says, what disease do we see Bence-Jones protein in? Well, you should think multiple myeloma. And what is the most common cause of death in multiple myeloma? Well, infectious disease. So you just have to be able to kind of pick and choose the important pieces out of these. So also know the difference between a monoclonal and a polyclonal gammopathy. I think sometimes there's some confusion with that. Monoclonal gammopathy is usually where there is one single type of immunoglobulin being created over and over again. It's usually some type of malignancy. Multiple myeloma is an example. We see a lot of excessive proteins, okay? This is where we see the Bence-Jones proteins. We see a sharp spike in that the M region, and then the bottom serum protein electrophoresis, we can see that. Waldenstrom's macroglobulinemia, think macro, think big, a lot of IgM, okay? Now, a polyclonal gammopathy is usually several different types of abnormalities within one electrophoresis. So in the middle one here, we've got some several different abnormalities, and that usually is caused by issues that are not malignant, like renal failure, you know, some other odds and ends and things like that. All right, the next thing, I'll try and move this over a little bit for you. Oh, my whole screen doesn't really fit really well. Well, we'll do what we can here. Okay, so with tumors, you have to recognize what test goes with what area of the body. So CEA is usually colon cancer. Okay, we learned about this in chemistry, so it's not really a surprise. CA15-3 is breast cancer. CA125 ovarian, CA19-9 more pancreatic. PSA is a prostate cancer that's used for screening. It's the only one that's used for screening. Alpha-fetoprotein, liver cancer, which like hepatocellular carcinoma, also testicular cancer, and spina bifida. I have a note down here on that. We can use beta-HCG as a pregnancy test, but it can also be used for testicular cancer as well. There's a few other ones on here that just happen to be in this chart that aren't really mentioned too much in your book, so I'm not going to talk about them too much. But the ones that I just mentioned are of importance. All right, boy, I wish this all fit on one screen. Okay, so for blood banking, we use the direct antiglobulin test to determine whether there's red blood cells if they're coated with immunoglobulin or complement. That's done in vivo in the body. The indirect antiglobulin test is used to determine the presence of an antibody in the serum or plasma. If we do it at room temperature, we're looking for IgM, and if we do it at 37, we're looking at IgG. I'm going to slide the screen over a little bit here, and when you look at different blood types, okay, know that if you're group A, you have A antigens. You can see them all stuck on this A cell, which means you've got B antibodies, okay? If you're group B, you've got B antigens, then you've got A antibodies. If you're group AB, you don't have any antibodies, and if you're group O, you don't have any antigens. So it's really important to memorize these two, that type AB plasma is universal plasma donor, and type O cells are the universal blood donor. All right, organ transplantation. So when we look at donating an organ from one person to the other, our major histocompatibility complex and HLA antigens come into play. Your body can recognize itself as self, and you don't want it to reject the organ that you're getting, but you don't have any control over that. Some of the different types of transplantations that we can do are autografts. That would be if you had a burn and they took some skin from your leg and put it on your arm. You can have a syngraft, which would be genetically identical twins. An allograft is between human to human, and a xenograft would be like a pig heart to a human. We do have to give anti-rejection drugs in order to stop this rejection process from happening. Cyclosporin, steroids, tacrolimus or FK506, and sirolimus are some of the ones that you'll see that they do give these patients, and we do drug levels on those as well. Be familiar with what graft versus host disease is. This is where the donor's T cells react against the host tissues. For an example, a bone marrow transplant would attack the recipient as being foreign. So it's kind of opposite of your own body rejecting an organ. It would be the organ rejecting you. Okay. They do bone marrow transplants sometimes on cancer patients. It's done on Hodgkin's lymphoma patients. And I'll just put a little plug in here that the cells of a Hodgkin's lymphoma have those little owl eyes and that bilobe nucleus. You probably learned about that. Or maybe you will be learning about that in Heme 2. No, you did learn about that in Heme 2. All right. Next is the primary immunodeficiencies. Okay, we had some struggles with this, a lot of struggles with this on our Module 9 quiz. So let's make sure that we really know this, okay? If I give you a definition, you need to be able to pick out which one it is in a multiple choice list. So this is where you're going to get out your note cards and really go to town, okay? Agamma-globulinemia means absence of antibodies. If you have a hyper IgM, well, that sounds like what it does, right? It's a high IgM, low IgG, low IgA, low IgE. We have a CVID. This is where the B cells are normal but do not develop into plasma cells. We've got CD27 positive switch memory B cells that are drastically reduced. Initially may make their own immunoglobulin, but then over time they don't. Okay, that's CVID. XLA, also called Bruton's disease, is X-linked agamma-globulinemia. X-linked means boys usually get it. We see a lack of mature B cells and a lack of tonsils as well. DeGeorge. With DeGeorge, we see a T cell deficiency. Those patients usually need a thymus transplant. Purine nucleoside phosphorylase deficiency. This is an issue with the purine salvage pathway. So it degrades and converts to different metabolites, but if it's defective, it builds up deoxy-GTP, which is toxic to those T cells. So we end up with a T cell deficiency, kind of like the DeGeorge. ADA deficiency is adenosine deaminase deficiency. This is a T and B cell type of toxicity. Reticular dysgenesis, where there's a complete lack of monocytes and neutrophils. We can have an X-linked SCID, severe combined immunodeficiency. This is the boy in the bubble. Very low T and B cell lymphocytes, and we have a deficiency in the stem cell development. There can also be complement deficiencies. We can have chronic granulomatous disease, where there's a defect in the subunit of NADPH oxidase that results in a decreased ability to kill. And that famous LAD issue that baby had with the umbilical cord not falling off, and infections from that discussion post, right? So the bacterial infections come on early on, and the umbilical cord usually doesn't fall off with that. So if you make note cards of what I have on this slide, you'll probably do very well. Okay, so just know these minor definitions. You don't have to be experts in every single one. Just know the difference. And I have a little side note here that infections suggest defects in antibody production. That's usually bacterial. Okay, so if you have bacterial infections, it's usually because your antibody production is pretty wonky. Oh, here's a slide that fits. Oh, sorry. All right, next is AIDS, okay, acquired immunodeficiency syndrome. Some of the characteristics that we see, and you have to know these, okay? The HIV glycoprotein 120, know that GP stands for glycoprotein, GP 120, GP 41, those are all glycoproteins. But the HIV glycoprotein 120 attaches itself to the T cell CD4. Okay, that's where it attaches. GP 41 and 120 are glycoproteins. 41 is usually what we test for when we do the testing later on. I'll get to that. AIDS is actually the 4th leading cause of death worldwide. It's held in leukocytes and it's carried in fluids. In HIV, the window of seronegativity is usually 6 to 12 weeks. And HIV usually lasts about 10 years until it turns into AIDS. We find that these patients have a lot of opportunistic type of infections. We've got the pneumocystis carinii, CMV, TB, toxoplasmosis, herpes, Legionella, histoplasma. They are also susceptible to a type of skin cancer called Kaposi's sarcoma. And over time, we see a very sharp decrease in the CD4 T cells. In order to treat this, we give them heart therapy, highly active antiretroviral therapy, and the NRTI, which is the nucleoside analog reverse transcriptase inhibitors. Those combinations help sequel that HIV infection so it doesn't switch over to AIDS. Once your CD4 becomes lower than your CD8s, you're considered to have AIDS, or less than 200 CD4s per, I think it's microliter. The testing, the HIV P24 antigen core protein is what we test for. Gotta know that, okay? The Western blot confirms it with the proteins 24, glycoprotein 41, and there's also supposed to be glycoprotein 120 and 160. Those confirm the disease. All right, the next thing was hepatitis. We talked about hepatitis in chemistry. We're bringing it back again to talk about some of the antibodies that go along with it. So you have a couple types, acute, okay, which is very quick, it's very typical. Fulminant acute is where it's rare, it's acute, but there's hepatic failure. We can have a subclinical hepatitis without jaundice, which is where you have the antibodies but you don't have symptoms. And chronic is where you've got something going on for more than 6 months. This can lead to cancer as well. So let's look at some of these different types here. Hepatitis A is a non-enveloped RNA virus with a nucleocapsid transmitted by oral, fecal, or contaminated water. We see elevated liver enzymes, bilirubin, jaundice. These are the ones that are usually connected to like a restaurant outbreak. Hepatitis B is the only DNA virus of these. Its transmission is through blood or blood products, okay, or transfusions, and body fluids. This one can lead to cancer. And we have different antigens. So let's say somebody's exposed to hepatitis. They're going to be exposed to that antigen. Okay, so if they have the antigen, hepatitis B surface antigen in their bloodstream, it means that they're actively sick. Once we see the hepatitis B E antigen, that means that there's a lot of infectivity going on, a lot of replication. Okay, the virus is replicating itself over and over. The antibodies start to come in after those antigens, right? So we can have an anti-hepatitis B core, means that there is a recent hepatitis B infection. And this happens between when the hepatitis B surface antigen disappears and the surface antibody appears. So it's kind of in between. So it kind of tells the doctor that they're starting to maybe recover. The hepatitis E antibody and the hepatitis surface antibody develop during convalescence and recovery. It's important to know that the hepatitis B surface antibody and the anti-hepatitis B surface are the same thing. Okay, just want to point that out. You're going to see it written both ways, different places. Next one is hepatitis C. This one's usually blood or blood products. Again, they're usually IV drugs. Slowly progressive, it can be silent. This one can lead to cancer as well, just like hepatitis B. Hepatitis D is a Delta virus. Only people that have hepatitis B can get it. So you have to get hepatitis B in order to get hepatitis D. Hepatitis E is fecal oral, but that's more third world countries. Don't see it a whole lot around here, but poor water sanitation can cause that. The last one's hepatitis G, closely related to hepatitis C. It's very common. Blood donors, usually 1 to 2% of them test positive, but you don't really even get sick from it. All right, mono is next. So mono is caused by the Epstein-Barr virus. Epstein-Barr virus can cause a number of things, right? It can cause Burkitt's lymphoma, infectious mono, nasopharyngeal carcinoma, and neoplasms of the thymus, parotid gland, and larynx. It's from the herpes family, and it's transmitted by contact with oral pharyngeal secretions or possibly blood transfusions. 90% of adults have been exposed to it, so therefore they have antibodies to the virus. It's usually asymptomatic in kids, but if they do get sick, it can cause fatigue, malaise, sore throat, fever, lymphadenopathy, and splenomegaly. We also see an inflamed, like a liver. They push on that liver is very tender. And one of the things that we put along with this is heterophile antibodies. Know the definition of this. Heterophile antibodies are an antigen that is present in different species, but not in relation to the evolutionary relationship of the animals. So when these can occur and they can interfere with our testing. That's kind of the problem with it. So we need good testing that doesn't cause a cross reaction with these heterophile antibodies. Okay, so heterophile antibodies react with horse, ox, and sheep RBCs, but they're not absorbed by guinea pig kidney. So if you mix a serum with guinea pig kidney first, you absorb the heterophile antibodies, and then you use the horse, ox, or sheep RBCs to react with the blood cells to see if there is the mono there. Okay, so the diagnostic evaluations includes a CBC. Okay, we usually see atypical lymphocytes if it is there. There's a Paul Bunnell, which is a hemagglutination that uses heterophile antibodies with antigen-bearing sheep RBCs. This picks up Forceman as well, Forceman antibodies. Then there's the Davidson. Davidson distinguishes between heterophile antibodies that agglutinate the antigen-bearing RBCs of sheep, and there's a guinea pig kidney that absorbs other heterophile antibody types so that it doesn't interfere. All right, next one is CMV, cytomegalovirus. This is from the herpes family as well, and it can spread from cell to cell. So it spreads to the lymphoid tissue and it circulates in the lymph nodes. We can have an oral, respiratory, or venereal route. There can be congenital infections. People are usually asymptomatic, but you could have a sore throat, fever, swollen glands, chill, malaise, kind of like the flu, right? It's only life-threatening to immunosuppressed patients. Okay, so cancer patients usually get CMV negative blood. HIV patients could be could be affected by it as well. So with this, it alters the immune system. It can alter the T lymphocytes by increasing the number of CD8s, kind of like HIV does. And the presence of antibodies against the intermediate, early, and early antigens associated with those active infections. So IgM is an active infection just like everything else. All right, the next part we're going to talk about is that torch profile: toxoplasmosis, other infections, rubella, cytomegalovirus, and herpes simplex virus. So we'll start with herpes simplex 1 and 2. This usually causes a cold sore at the mouth, but can also cause genital lesions. Type 1 is traditionally a cold sore. Type 2 is traditionally a genital lesion, but they are found both places. Some of the symptoms are, again, that painful blister. It can last 2 to 4 weeks and can reappear more than once. Rubella infection, also known as the German measles or the 3-day measles, is a RNA virus that can cause very detrimental things to a fetus. So if a mother is not vaccinated, they can acquire this type of infection, and it would be devastating, as you can see by the picture above. Some of the other viruses are shingles, caused by varicella, very painful. Rubella is German measles or 3-day measles, okay, that can cause that congenital rubella syndrome. We just talked about that. Measles is usually protected by the MMR vaccine. Mumps, that one is causes a swollen parotid salivary glands. You see this guy with a big lump on the side of his neck. We see fever, headache, muscle aches, loss of appetite, fatigue. That's also covered in the MMR, measles, mumps, and rubella. West Nile virus is one that's just come out probably in the last 10 years. This one is caused by, mosquitoes. And influenza, that's one that usually we get a flu shot every year, especially if you're going to work in healthcare. This one is interesting. Well, actually, yeah, this one is probably the most interesting one because you have to get one every year due to antigenic drift. So just because you have a flu shot in 2017, you have to get another one in 2018 because there's the antigenic drift, which may cause the strain to not, your body to not recognize it because of that antigenic drift. And that concludes the whole review section for the Immunology Exam 3. I recommend using these slides as a study guide and making some note cards so that you're prepared. Every question is covered in these PowerPoint slides. I went back and I double checked and made sure that they're all there. So if you know everything that's on these slides, you're going to do very, very well. Have a great weekend.